Welcome, future emergency nurses. Let's jump right into this explainer. Today, we're unpacking the clinical profiles of three major viral threats you are absolutely going to encounter on the floor. Look, when you're on the front lines, understanding the exact pathophysiology and transmission mechanics of these viruses, it's not just academic. It literally dictates your triage decisions, your infection control protocols, and ultimately your patient's outcomes. So let's get into it. Consider this your shift briefing. We'll be detailing the seasonal threat of influenza, the hidden congenital danger of rubella, and the complex management of HIV, wrapping up with exactly how your role as a nurse ties it all together.
All right, Section 1, Influenza, the shifting threat.
So, influenza. We all know it's an acute respiratory tract disease that notoriously hits in epidemics. It's a small enveloped virus with several strands of RNA. Now, while the strains might look pretty similar under a microscope, their actual behavior is vastly different. When you're in the ED, type A is really your primary concern. Why? Because of its high mutation rate, a phenomenon known as antigenic drift. This drift is what causes major worldwide epidemics. It's just in a continuous state of antigenic change. Type B, on the other hand, is much more stable and only rarely causes epidemics, while type C is just a single stable form that pops up sporadically. Now, for triage, here's the specific cluster of signs you need to look out for. The virus spreads super easily via droplet nuclei from both clinical and inapparent infections. After a really short 1 to 3 day incubation period, your symptomatic patients are going to present with chills, muscle aches, malaise, and a heavy mucus discharge from the nose and throat. But pay attention to the distinct markers for your charts: a characteristic 3-day fever and severe prostration. Of course, the flu is serious on its own, but you've got to stay vigilant because it's usually the complications that actually bring patients into the ER. A massive clinical red flag to anticipate: secondary bacterial pneumonia. This is typically caused by streptococci and staphylococci, and it's especially dangerous for severely debilitated or elderly patients. You also need to keep a close eye out for cardiovascular and renal diseases, which can develop rapidly as complications of that initial infection. Because natural immunity after a flu infection is incredibly short-lived, mostly thanks to the short life of IgA antibodies and that rapid antigenic drift of type A we talked about, vaccination is our absolute best tool. Just remember, these vaccines are prepared from viruses grown in embryonated eggs, so they're strictly contraindicated for patients with egg hypersensitivity. Also, since these vaccines won't completely stop broad epidemics, your immunization efforts really need to target these specific high-risk groups: the elderly, nursing home residents, and anyone dealing with chronic respiratory, heart, or renal diseases, diabetes, or immunosuppression. Okay, moving on to Section 2, rubella and protecting the unborn. Also known as 3-day measles or German measles, rubella is an unclassified RNA virus. In adults and kids, it's a pretty mild illness, but we're focusing on it today because of its absolutely devastating congenital consequences. This timeline here is critical for your infection control protocols. Notice that 2 to 3 week incubation period. The clinical picture usually involves some malaise, slight fever, and a mild rash that starts on the face and trunk before moving to the arms and legs. But here's the kicker: the virus spreads via nasal secretions 4 days before and 4 days after that rash even shows up. Within 3 weeks, the body produces IgM antibodies, which thankfully give lifelong immunity. But what's really wild is the sheer scale of the threat to the unborn. If a pregnant woman is exposed and the virus crosses the placenta, within the very first month of pregnancy, a staggering 80% of children will show severe malformations. This is congenital rubella syndrome. It typically involves severe tissue damage to the eyes, causing cataracts and blindness, the ears causing deafness, the heart resulting in septal defects, and the brain leading to mental retardation. And even if that maternal exposure happens a bit later, say within the first 4 months of pregnancy, there's still a massive 25% risk of congenital rubella syndrome. This terrifying statistic is exactly why public health policy fundamentally shifted. Rather than just trying to protect women of childbearing age, the goal became eliminating the circulation of the virus entirely. We do this through the combined measles, mumps, and rubella vaccine, the MMR, given at 15 months and then again between 10 and 14 years of age. Let's turn to Section 3, HIV, immune system under siege. For our third pathogen profile, we're looking at the human immunodeficiency virus, or HIV, types 1 and 2. This virus presents a really complex spectrum of disease, the most severe form obviously being AIDS, and it requires a massive paradigm shift in how we approach patient care on the floor. Let's trace how this builds clinically. HIV is usually transmitted through sexual intercourse, but also via blood transfusion, IV drug use, and transplacentally. The initial infection, it's usually subclinical. From there, most patients enter a symptom-free incubation period that can actually stretch anywhere from 1 to 10 years. During that time, the virus, which has a specific affinity for helper T lymphocytes, actively destroys these vital immune-regulating cells. That destruction eventually leads to AIDS, leaving the patient highly susceptible to a huge variety of viral, protozoal, fungal, and bacterial infections. As an emergency nurse, you absolutely must know this definition by heart. AIDS patients often develop various malignancies, most notably lymphomas and Kaposi sarcoma. Kaposi sarcoma is a malignant, multifocal neoplasm of the reticuloendothelial cells. During triage, you'll often spot it first as brown or purple patches on the patient's feet. From there, it spreads across the skin, metastasizing to the lymph nodes and viscera. Now, after that long deceptive incubation period ends, roughly 80% of patients are going to develop one of these severe clinical syndromes. This might look like a profound depletion of T4 lymphocytes coupled with serious respiratory threats, like pneumocystis carinii pneumonia. It can present as persistent generalized lymphadenopathy. Neurologically, we frequently see severe brain involvement. Think dementia, psychosis, or encephalitis. Physically, you might see a barrage of opportunistic infections causing herpes simplex in the eyes, or chronic ulcerations of the nose, mouth, and tongue. And finally, Section 4, the nurse's crucial role. Look, understanding the virology and pathophysiology is really only half the battle. Let's talk about your critical role in clinical management and patient education. It's so important to note that the primary protocol right now centers on supportive measures and targeting those opportunistic infections. There is no specific cure. Because of that, management leans heavily into public health and prevention. We're talking screening donated blood, investigating for carriers, providing rigorous counseling for antibody-positive folks, and strongly advocating for modified sexual practices like using condoms. Your mandate on the floor is pretty clear. HIV is a serious, chronic impairment of the immune system. Your patient is just striving to maintain some sense of normality, trying to keep symptoms under control and not let the illness completely consume their life. As their nurse, you have to help them redefine their clinical goals from a cure to wellness. But to do that effectively, you really have to look inward first. HIV is an illness that's often clouded by rampant myths, misconceptions, and completely unwarranted connotations of sin or evil among the general public. And yeah, sometimes even within healthcare. To provide truly competent care, you must actively explore your own feelings about homosexuality and intravenous drug use. You've got to break down those internal barriers of fear and denial before you can ever hope to effectively reach and treat your patient. Ultimately, your most powerful medical intervention here isn't a syringe, it's education. Since a vaccine for HIV infection is still a distant prospect, education is literally the only reliable mode of intervention we have. Behavioral change, the kind that actually stops transmission, is only going to happen if individuals truly understand their vulnerability to the virus. And there's no way they can understand that vulnerability if the conversation is blocked by fear and denial. So as you gear up to face these complex viral threats in the ED, from the rapid mutations of influenza to the hidden dangers of rubella to the chronic immune-compromising reality of HIV, ask yourself this. Are you ready to look beyond the pathophysiology? Are you prepared to confront your own biases, redefine wellness, and provide the empathetic, educated care your patients so desperately need? Keep that in mind for your next shift.